During the 2016 American Academy of Ophthalmology meeting, Duke Eye Center held educational presentations in our exhibit booth. We hope you enjoy watching the faculty sharing the latest in ophthalmology.
My name is Christine Shieh, and this is Dr. Anthony Ko. It's our pleasure to be here with you today to speak about microscope integrated OCT for the anterior segment. Dr. Ko is a consultant for Clairvista and also has some patents with Leica. I have no financial disclosures, but we do want to acknowledge that swept source MI-OCT is considered an investigational device and is not yet FDA approved. Now, historically, it was one solution fits all for any corneal disease. The corneal surgeon, it didn't matter whether there was disease as a scar in the anterior stroma, corneal ectasia or instability in the biomechanics of the cornea, or endothelial disease, those pump cells that line the cornea. It was PK or penetrating keratoplasty for all, a full thickness cornea transplant no matter where the area of disease was. We're fortunate with the advances in corneal surgery that we're able to become increasingly sophisticated in how we target the area of pathology. This picture here of a patient with pseudophakic bullous keratopathy, or disease of the endothelium, the inner lining of the cornea, is now able to have, instead of a full thickness cornea transplant, to have a lamellar or partial thickness cornea transplant, thereby enabling the patient to have faster visual rehabilitation and, as much of the literature suggests, potentially lower rates of rejection. Accompanying these increasingly sophisticated surgical techniques has also been technological advances, which allow the surgeon to refine and potentially improve the way that they perform anterior segment surgery through OCT. Dr. Ko?
So in contrast to the advances that have been made in the surgical techniques, the surgical visualization is not really advanced very much at all. So over 100 years ago, you would use loupes, which is basically magnifying glasses. And then in the 70s or so, they came up with the steerable surgical microscope that you see nowadays, and that is it. So nothing's really changed for decades and decades. In the outpatient world, things have changed with the advent of OCT, so you can now get three-dimensional renderings of what you're seeing in the cornea, and so that's a major change. And what we'd like to do is bring these sort of changes that are available to the outpatient setting into the surgical setting so that we can see things in microscale and 3D. So bringing OCT to the OR means stuff like this. So in the top left up here, that's the view. There's actually another cornea stuck behind that cornea that you can see. Well, actually, you can't really see in that view, but there is one other. If I hadn't put that little purple line there, you wouldn't know there was another one behind it. If you could do the OCT cross-section, it's very easy to see that there's another extra piece of tissue here, and there's some space in between. That space in between is bad, because that means these two won't work together as a single cornea. And we want to identify that before you see them post-op the next day and realize these two things aren't attached. So if you can, in the OR, tell there's a space here, there's no space, this is good to go, this helps us so that you don't have complications afterwards post-operatively. So this is an advance, we feel, in visualization to match those advances in surgical technique that Christine was talking about. And so there are different vendors now. So this has gone to the point where a couple years ago we were doing in research. It's now moved into commercial land. So if you go out on the floor here, if you stop by Zeiss or Hogstrite or Leica, you'll see that they have commercial versions of this. And they have it in two-dimensional, meaning they can only give you a single slice, and that's it. So we're going to show you now what we're doing in the lab, which is doing three-dimensional versions of this. And that starts looking like this. So it's not just sliced anymore. Now you have three-dimensional information. So here's a needle going into the cornea. You can see that there's an air bubble expanding. You can see us removing tissue off the cornea. So at this point, you don't really need the surgical microscope anymore because all the three-dimensional information you need to operate is already here. So this is, we feel, another advance over what's out on the show floor here. These are some other examples. So this is in corneal transplantation. Here you can see the iris, or the colored part of the eye, stuck to the cornea. And so with the little viscoelastic, you can push that part down. This actually, the surgeon couldn't see that part rising up in the regular surgical view, so we just happened to see it as we were scanning with OCT, and we told them, hey, you need to push that part down. If you don't push that part down, that becomes permanently stuck, and then you affect the glaucoma drainage in that area. So this was really helpful for them to see, and we can guide them and tell them, okay, if you go down to 7 o'clock area and push that down, that'll get that part away from the cornea. This is phacoemulsification, which is cataract surgery. You don't really need fancy visualization because people are really good at cataract surgery now. But this is just kind of cool to see what this looks like on a 3D scan. Okay, these are other things we can use with OCT. So this is a corneal incision that was made from cataract surgery, and what you want to make sure is that this incision is nice and tight, because we don't put any sutures in this, and you don't want them to walk out of the OR and then have their eye leak out and then have a flat eye the next day. So the usual way you do this is you kind of poke the eye until you see whether there's fluid coming out or not. This is a much more direct way to look at the incision. So instead of poking at the eye and then seeing if fluid comes out, we can basically directly look at it, and then you'll see we'll have our little Q-tip-like thing pushing on the cornea, and you can see each time the cornea gets deformed, nothing's really happening to the incision. So we know this is a really tight incision. They'll do fine afterwards, as long as they don't rub their eye too hard, versus one where it's gaping open. And so this is a direct way to look at this sort of information.
We can also use microscope integrated OCT and lamellar keratoplasty, as I mentioned earlier, in a technique called DSAEK. And in this, you actually want to take off the diseased front surface of the cornea, and there are different ways that you can do this. You can either do this with manual dissection, kind of cutting through, peeling it layer by layer, or something called the big bubble technique, which is where you introduce a needle into the cornea and blow a big air bubble to try to cleave the area between the stroma and the descemes. The descemes is the healthy layer and the endothelium in diseases such as keratoconus. So in cases of lamellar dissection, what OCT allows is for the surgeon to see exactly how much residual cornea is left as they're peeling off those areas, because the key is to be deep but not too deep. You want to peel off the diseased area, but you want to preserve the descemes membrane. And so this allows the surgeon to gauge the depth as they progress. Furthermore, in the big bubble technique, you can imagine when you're putting a needle through something's clear on clear with a top-down view, it's hard to tell exactly how deep you are. So with MI-OCT, we can actually follow the progress of the needle as it tracks through the cornea, such that we're deep enough to create a successful big bubble, but not too deep that we perforate through that descemes membrane. OCT also permits needle guidance, and also one can even visualize the formation of the big bubble with the use of OCT. And DSAEK, which is a different type of disease, treatment for disease where the endothelium is diseased, but the front of the cornea is healthy, we actually want to replace that diseased inner layer of the cornea. And so what OCT can permit is also tracking the performance of the graft inside the anterior chamber. Here, as air is injected, we can see that the graft comes closer to the host cornea. Furthermore, interface fluid in DSAEK is the enemy of the surgeon. We want to try to have that new graft lenticule perfectly opposed to the donor host, such that there's less chance that graft will detach and that we'll need issues of rebubbling. And so here's an example actually in the operating theater where the surgeon had not been aware of fluid, but we were able to release it. And this is a scan going throughout the entire cornea showing that there is no interface fluid. The surgeon can therefore leave the operating theater feeling confident that there is no fluid and that there is very unlikely chance that the graft will detach.
Yeah, so this is three-dimensional information. So if you use a current two-dimensional system, it either gives you a couple scans through the cornea, or you have to kind of move your scope and get the scans to the right position. This is three-dimensional. You basically capture it in one volume, you flip it over, and then basically you can run every scan through the cornea, make absolutely sure that there's no interface fluid anywhere in this graft as you move along.
And where OCT can potentially shine especially is in those severe cases of pseudophakic bullous keratopathy, where you basically have no view of the anterior chamber at all. These are two patients who had severe pseudophakic bullous keratopathy, and you couldn't see into their anterior chamber at all. And what we can see here is that with the use of microscope integrated OCT, it's possible to visualize the graft and also to be sure that the graft is opposed. In this other example, we're able to see the graft once it's been inserted. And over here in that far corner, you can see that there's actually fluid between the graft and the host, which was not possible to visualize through the microscope. And so with the use of OCT, we're able to remove that interface fluid and therefore improve the patient's surgical outcome. Lastly, OCT can also help improve ophthalmology resident surgical performance. These are examples of ophthalmology residents of different levels of training where we looked at their surgical performance in passing a corneal suture at 50% depth and at 90% depth. Now, Group B, the group in green, had the use of MI-OCT to start off with. And what you can see is that they far outperform Group A, which did not have the use of MI-OCT, and achieving at 50% depth and especially at 90% depth. Now, we were curious, what happens when you take away the use of MI-OCT in that group that previously had the use of MI-OCT? Would they continue to perform well? Is it just a learning effect? Will Group A perform better than Group B? And what we find is that even when MI-OCT is taken away, Group B, which initially had the use of MI-OCT, continues to perform well, suggesting that there's a learning effect from having known where exactly to pass that suture beforehand. As we can see, Group A, the group in red, continues to perform about the same. So it's not that having a second chance allows them to perform better. Now, of course, the question is, did we inadvertently choose a group of residents who are just not as good surgeons as Group B? Does it have anything to do with MI-CT, or was it those residents in Group B just better surgeons? Well, what we found is that when we allowed Group A to have the use of MI-CT, they performed similarly to Group B, suggesting that MI-CT is really a key variable in helping ophthalmology residents learn how to perform surgery.
Okay. So these now are just random cool videos that we're playing, but so live 3D intraoperative OCT enables us to directly assess important steps in keratoplasty, and we think it's particularly helpful for interface assessment in endothelial keratoplasty and to help us do a lot of these more advanced corneal transplantations. And this is the work of a lot of people involved here at Duke, both at biomedical engineering, Cindy Toth's lab, my lab, and then we have collaborators outside as well. And also at the Duke Eye Center. Thank you very much.
Yeah, thank you.